Hi, and welcome to Straight from the Hip, honest conversation about hip and groin, podcast number 2. I'm Benoit, learning specialist from London, and joining me from Perth, Australia is Callum. And we know dealing with hips can be tricky, multifactorial, and it demands a lot from us. That's why we created this podcast. We're cutting through the noise and bringing you what actually matters in clinic, aimed for any clinician who deals with the hip and groin pain. And with each episode, we tackle different presentation. In episode 1, we went through the most important part, which is the subjective, and sort of set the scene and what you would really look for to have that high suspicion of hip impingement syndrome. And here we're jumping into episode 2, where we'll be looking into the objective side. So what have we got as for today, Callum?
Yeah, so cheers, Benoit. We've spoke a lot about the subjective signs and symptoms demographic last time. So this is now more, you've set the scene. You're, 60, 70% confident that you're probably dealing with an FAI. So now you want to use your objective assessment to try and dismiss or refute your working clinical hypothesis. So we said last time that most people will come in saying that they struggle with deep hip flexion, internal rotation type positions of the hip. So depending on how painful, how comfortable your person is, I generally, just because they're in the seat, we can get them to stand up. So if they say that doing a squat is painful, I'd say to them, well, can you show me how you squat? We're not too worried about necessarily how they're squatting. It's just their version of a squat. How do they feel when they're doing it? Now, I'd probably say from my experience, and again, I know, Benoit, we might talk about sort of femoral acetabular versions, torsions at a later date. But I think most guys, I don't know about you, Benoit, but I prefer squatting with my feet outwards, a bit wider, externally rotated. That's way more comfortable.
Yes, definitely.
I'm not someone that can narrow stance squat.
Yeah.
I'm that typical bloke on the train that will sit in a bit more of an abducted position with my legs. So generally you will find that men will tend to have a wider stance compared to women. And if they don't, let's just say they've got shoulder width stance because they looked up on YouTube how they should squat, and YouTube said, it's got to be shoulder width apart,
Perfect.
feet facing forwards. That's how you squat. But then they get into a squat, and let's say they get to a 70-degree sort of depth in the hip flexion, they say that brings on their pain. Just having a bit of an understanding of male femoral acetabular versions, if you got them to widen their stance and externally rotate their feet or evert their feet, can they squat low, and does that become more comfortable? I'm not saying it always works, but I would say more often than not in my clinic, that tends to feel a bit more comfortable for a guy that's squatting or split squatting, lunging or leg pressing. Just by having the feet a bit wider, that can be a bit more comfortable. So that's something I sometimes like to do, because I've ascertained that, okay, the squat, the deep flexion hurts, but we've also found a symptom modification strategy that means we can automatically start to modify their training if we're talking about the gym goer.
Yeah,
Do you find
definitely.
that, Benoit?
Definitely. I think, it's a great point. Yeah, definitely. I start with which is the main thing. Like the most gym goers, is the main thing is the leg press and the deep squats. So I'll always ask them, like, what's the position you do? And then you can make some modification, either an external or internal rotation. In fact, there's a test, I think it's something called walking, where you make them walk with slight internal rotation and then external rotation and see whether there's any difference. So what we're looking here is F4, so we can sort of, so we can check them, because it's the one thing which is relevant here is hip impingement FAIS syndrome is a motion related disorder. It's not something you develop because of weakness per se. It's how you move and the load as well. So we definitely have to see how they move, but we have to be careful not to label them that you got all these things going wrong, like, because what's perfect movement? What's a perfect squat? We could just spend the whole episode talking about that, and that's not the goal here. Is we want to see what really brings on the symptoms and what's the movement pattern they're using and where they're finding it's more really irritating that. So I think those things in clinic, I think most physios will use functional testing like the squat, single leg squat or a step down or things like that. So it's important that you have a bit of a routine. So what would you say, like, sort of your before you put them on the bed, what sort of your routine before you sort of analyze that?
Yeah, you sort of touched on it there, Benoit. So after we've done the squat, if it's a split squat, if it's a lunge, find the movement pattern that it could be all of them. So you might look at all of them. Just for the listeners, you reference the FPAW. So for anyone that isn't aware of this test, it stands for the foot progression angle walk test. So it was originally designed to get someone walking, as Benoit said. So if someone's got right hip and groin pain, you can start off. So if this is a bloke, you could get them to internally rotate their femur. So their foot would be inverted, pointing inward. Now, sometimes that could just cause their pain enough. Sometimes I would get them to go in that position and just stand on one leg. So now they're fully loading on that hip joint, internally rotated. Sometimes you can get them walking a few steps, and that can also be painful. The idea of that test is you would then get them to externally rotate their hip, so their foot now becomes everted, get them to stand on one leg or get them to take a few walks forward, and does that become more comfortable? Based on what we know about male, in particular, femoral morphology, males will typically prefer having their foot externally rotated compared to internally rotated. So again, that's something you can play with on a lunge or a split squat position as well to try. Can we internally versus externally rotate? What's more comfortable? Can we get a bit more depth externally rotated versus internal? And that's sometimes a bit of a sort of thing that I will do with them standing, particularly with the exercising person, because my opinion of it is that you don't always have to do your objective assessment to find out what is wrong. Can you symptom modify? Can you change things a bit, which then informs your rehab and the education that you give that person? So in standing, that's probably a lot of the things that I would do, but based on their sort of provocative factors before I then get them on the plinth.
Yeah.
Is there anything else you would do different or add, Benoit, to that?
Yeah. So I think one of the things we want to ask them is that people will report different things. So one is it a pinching feeling? Is it their pain? Is it more a stiffness? Is it a block? So I think it's really important to explore what they report because, for example, like, I have a type of hip which we can discuss later called retroversion, where I naturally don't like very closed squat. And for me, I don't have any symptoms, but I don't like that position. It feels like a block. So I think we need to explore that and say the couple of simple questions you can ask is, what are you feeling? Is it your pain, which you get when you do in the gym? Is it something you're feeling like a block? Is it like a pinching? Is it more a restriction? So because people will use different words, is it something you explore in the qualitative response to that? What do you say to that, Callum?
Yeah, so I think you've raised a good point there, Benoit, because a lot of things that we do as physios can be uncomfortable. That's why we're a bit like Marmite, is how I describe physios. You either love us or hate us. But one of the reasons why we're hated is because we tend to provoke symptoms of some description. So the thing that I would say to them is, look, we are probably going to do things in this assessment that aren't comfortable because it's not for most people. There's a difference between you just feeling uncomfortable with what we're doing, but is this producing your symptoms? So as we discussed in episode 1, is it the pinching? Is it the catching? Is it that deep ache, that stiffness, all that stuff we covered? Is what we're doing causing those symptoms? Or as you've described, Benoit, you just don't like a narrow stance squat. You're not in pain, you just don't like it. There's a difference between that versus this is my painful hip and groin pain that's limiting me. So yeah, absolutely. Very good point to raise.
And one thing before we start, even the objective, one of the things I look for is the irritability. For example, many times when I'm doing the subjective, I get a patient standing up within 15 minutes and say, is it okay that I can stand up during the examination? So I already know the diagnosis here. It's an impingement. So you'll have to be careful. Like, this is a mistake I've did in the first 4 or 5 years where I looked in the books, I've watched the experts, and I was super keen to try everything I know on the patient and poor patient. And then I do everything and they can't really walk for another 4 weeks. They're limping. I just flare them up. So I think we have to be careful because when we teach courses, it's good to know like 100 tests or 50 tests. But the reality is you're massively limited by the pain and the irritability. So for me, the basic stuff is, are they having night pain? Are they limping? Can they sit for more than 20, 30 minutes? That pretty much sets the scene, how much you go. So is it something, what do you say? It's important there, Callum? Irritability of the patient.
Absolutely. Yeah. And to be honest, this was a bit of a shock to my system when I did the FCP role. For anyone that's not familiar, first contact practitioner role, or like Benoit in an APP role, where you do not have the time to do loads of tests and assessments. And that was a big shock to me, where I had all these tests in my mind, wanting to do them all, don't have time to do it. But as you rightly said, you can stir someone's symptoms. So if someone's getting night pain and they're struggling to sit, struggling to walk, I don't really want to mess around with their hip too much, because if anything, you're going to annoy them further as well as their hip, and they're not going to come back and see you because you'll just be remembered as the physio that stirred up their hip more than it already was. So definitely,
Yeah. And one thing I've done which make a big difference is I always warn them and say, it's quite sensitive structures around the hips, like the capsule and the labrum. So it's quite normal to feel a bit of pain. So I had some patients where they came back, where they've seen other therapists and say, I've seen this person and they just damaged it and made it worse. So I obviously, I say to them, no, it's impossible to do that. Maybe it was quite too strong. So it's always good to mention to the patient that you can't physically damage by examination, but it can be a bit painful for a few days. So they don't feel like you're causing any damage, because that's something patients without that sort of specific knowledge will know that. So I think making them feel like that a bit of pain is normal. But obviously, if it's too, I always say to them, if anything makes you feel uncomfortable or is too much, please let me know. And you get this. I don't know whether, but I get this annoying group of patients where they come in without taking any painkillers because they want it to be fresh for me. They,
yes,
they want it to be like, I say, like,
absolutely.
They come in pain. They're not slept last night because they wanted me the best version for me. And I said, like, why are you doing this? I'm not getting any joy from seeing you in pain. So I'll always ask them, have you had any painkillers? No, are you taking any painkillers? So they don't have to be fresh for me, because I don't need that sort of extreme pain for me to make the diagnosis. So these are some simple tips here, but checking the pain levels, warning them not to let me know if I'm doing too much, and telling them about post objective assessment residual soreness is a very normal thing. So we don't want to make them feel threatened or walk away. So some good points there, so we can highlight them. So how do you move forward from the functional testing? How do you sort of take the assessment forward, Callum?
Yeah, I think the only other things that sometimes I throw into I suppose you call it a functional assessment, is the stepping up, step downs. So if someone is saying that they're struggling with hills or with steps, I suppose it depends on what you're asking. So probably the biggest thing I see is sort of a lateral trunk lean. If someone's going to step up, they'll just chuck their entire trunk to that particular side, to that, if it's their right hip, to the right side, or they'll kind of do a bit of a hitch with their hip because they just can't translate that force forward, and they're trying to limit as much as they can the hip flexion and loading through hip flexion onto their hip as they step up to a step. These are just some movement patterns that we can see, and I suppose that comes down to a lack of lumbo-pelvic abdominal related control. It's not because they're weak, and that's an important point I think you already said, Benoit, was that the weak is them. Someone being weak does not cause their pain. This is the effect of pain, is that their muscles have become weaker. They've altered how they do things, so naturally muscles become weaker. So they're probably functionally wise, that's probably where I leave it.
Yeah, definitely.
Providing we're actually able to do that.
Yeah. And the step down test is a good functional marker as well. So you look at the hip drop, you look at the control of the pelvis. So I find the lateral step down is something I use a lot with my hip patient. And the good thing is, most nowadays we have videos. I ask them to video on the phone. I can show them. And then we can say, once we've done the strengthening, we can examine them. So sometimes the assessment itself becomes like a marker of progression, because then we can reevaluate that in a future state as well. So that sort of set the scene. So when you're going into the bedside, a couch-based test, there's thousands of tests. There's so many special tests. So how would you sort of layer this and structure this sort of couch-based assessment?
Yeah, so I suppose you want to try and limit as much movement as possible. You don't want to be getting the patient up and down, twisting left, right all the time. So I would get them lying supine, and you could do probably majority of it there. So because we know hip flexion is the problem, start with hip flexion passively. Because as I think, Benoit, you either said it in this episode or a previous one, it's a motion position related pain. It's not something that's absolutely governed by load, like you would think of a tendinopathy, for example. It's motion position related. So passive hip flexion. Can you find that there is a sort of a blockage? Can you feel that there's a hard or even a soft end feel? Are they apprehensive? Is that range of movement, I suppose, less than about 110 degrees by comparison to the other side? That's what you're looking for. Their familiar pain in the groin. Is there restriction in range of movement because of pain compared to the other side? On that point, I don't know how you handle it, but no, kind of the handling of someone's leg. But I suppose I was taught at university, and I see a lot of physios have their hand on someone's knee and have their hand on the foot, and they have quite a lot of space between their body and the person's leg, and they'll just rotate and move the hip around like that. That's not how I teach it. Because I say to people, that's effectively an active assisted test. That's not a passive test. And I think as physios, we're taught with shoulder instability or shoulder joint stuff to really cradle the arm so that you're testing the joint. But for some reason with the hip, we're not taught that, and we don't do that. So I always encourage people to make sure you're cradling their leg. However which way you want to do it, get your body nice and close to their leg. get your arm under the leg. Make sure it's passive when you're doing it. The patient needs to feel like you have got their leg, and just
Yes.
having your hand on the knee and foot and moving it around. That's
Yeah.
not how I would do it
Yeah.
personally, and that's how I
Yeah.
teach. How
Yeah, and definitely they feel more supported. And one thing we want to avoid is pushing into that pain, where like the traditional quadrant test, which was designed for hip OA, has very limited utility in that. So we don't want to really trying to ram in, because anybody, if you push them into too much of internal rotation, will start hurting, and then we know that's a problem. So I think they should feel secure and good handling there, and obviously make sure that appropriately dressed, and you might need chaperone for some testing, so they feel comfortable with you, sort of. And obviously, like odd good clinician, we explain what we're doing before. So we tell, like, we're looking for this, so we go through that sort of thing. So and then obviously when you look from the literature, there's a lot of special tests and other things. So what would be sort of your key priorities here to look for, and also things like picking up other muscle groups like the adductors or the GTPS, because sometimes a lot of them will have muscle pathology coexisting as well. So how do you prioritize that, Callum?
Yeah, I mean, I'm prioritizing assessing the joint initially, because if I'm thinking it's a joint problem, I want to assess that. So I probably would just go for a passive hip flexion as far as is comfortable, look for a restriction in range. I then tend to test their internal rotation. Now, there is two ways of doing this. You either keep their hip at about 90 degrees flexion and just internally rotate it. And do you notice that there is a reduction in range of movement right to left? There was a paper that came out a few years ago that suggested testing internal external rotation is actually more accurate when the patient is prone.
Yes. Yeah.
Less opportunity for compensation. It provides much more support, makes your handling easier. And because you've got the shin angle, if you're using an inclinometer, dynamometer, you can actually see the shin angle to get a much more accurate measure of someone's internal external rotation of the hip. I can certainly understand that you may not be able to get every patient prone. It's just an option, something to consider. And the other one that I think a lot of people are aware of is the FAIS test, the flexion, adduction, internal rotation. The biggest point I would raise to that is, I think you said it, Benoit, make sure you explain what you're about to do and that this can be uncomfortable anyway, but is this your pain? Take them through flexion, apply the adduction and then internal rotation, but don't go through the entire test. If you get to flexion and then some adduction and it's causing their pain, don't then jam it further and add the internal rotation. Like, in my opinion, it's not necessary. That then becomes a positive FAIS test.
Yes.
They're probably my top ones that I would do.
Yeah. And well, another thing is people always ask me about the Faber testing, which was historically designed for the SIJ. Do you think it has much role? It doesn't add much from the sensitivity and specificity, but something I look routinely is look at that sort of range of motion. I use it more like a range of motion testing rather than for diagnosis of pathology. So sometimes just to look at how much, because it's a combined movement. Is it something you use as well for looking the combined movement?
Yeah. So when I was in my primary care clinic, I'll be honest, I didn't use it at all. And it's more because I didn't have, I was less time. I had 20 minutes, so I thought that's not going to add any real value to me here.
Yeah.
But because it's not a great test. I mean, none of these tests
Yes.
are great. We can save this for another time. But
Yeah.
the Faber test, you can measure. I assume this is what you're referring to. You can measure kind of the lateral knee and down
Yes.
towards the side of the plinth. So if you are wanting to get a measure, you can put a stick, if you've got one available, kind of between the patients underneath their knees. Take them into the Faber pose. Make sure you're stabilizing the contralateral pelvis. And you can do it yourself or get someone else to measure the sort of lateral aspect of the knee down to the plinth, which will give you an idea of what their combined abduction, external rotation, range of movement is compared to the other side. And most likely, you'll probably find that there is a reduction by comparison of the symptomatic versus the asymptomatic side.
Yeah.
Not
Unless
always.
you've got bilateral cam or because many cases bilateral,
Okay,
isn't
yeah,
it?
you can.
So then so you can't really do that. But again, it adds to the picture. So a couple more things before we, which I'll be keen to know your opinion is, one, we know in most places, like, we are having access to handle dynamometer for more accurate testing of the strength. So I guess with any lower limb, we're looking at the strength side. So how would you prioritize your strength testing? You can't do all the 6 groups. So do you have like a particular preference or different groups you would expect? And we discussed earlier that the weakness is more towards inhibition rather than true, driver. So what would your priority to look at sort of the strength element?
Yeah, I think what we know with the research, and this I think goes for intra-articular hip pain as a whole, we know that the hip abductors typically suffer quite
Yes.
heavily. And again, it's pain is your inhibition. So pain or arthrogenic inhibition are going to be your drivers. So I would be looking at hip abduction strength. If you've got a dynamometer, yeah, amazing, you use it. If you don't have it, then it's going to be the case that you get them side lying and you test their abduction resistance. If you want to put it into an exercise pattern, you could try different versions of a long versus a short lever side plank type thing if you're trying to feed it into an exercise. But I'd say the hip abductors is a key one. Hip flexors, they're naturally going to be weak because that's the movement pattern that jams into their hip. So it's normally a movement they're trying to avoid doing. So I think hip flexion strength is going to be another one. Extension strength, it really depends. You can find, and then maybe this is more a case for a dysplastic hip, but I've certainly seen it with an FAI hip. They have reduced peak hip extension torque. So they'll reduce their hip extension with gait, because that can also be provocative. So if I had to pick my top 3 for the initial consultation, they would probably be my 3. But we also have to acknowledge that the adductors are probably going to be weaker. Their abdominal strength and obliques are probably going to be weaker as well. But if we're just thinking about that initial consultation, I would probably prioritize those 3 initially.
Yeah, definitely. And one thing which we don't want to miss is look at the whole kinetic chain and the whole system. So there's a lot of tests which we can use. For example, like the single leg sit to stand, like the single leg rise test, hamstring, bridging, abductor strength. So what do you think about looking at the whole system, and what sort of rather than, they are not really true strength testing, I would like to call them like more capacity testing, because you're looking at the capacity there. So what sort of things you look out for there, Callum?
Yeah, so the stuff I just mentioned is your isolation, or as isolated as you can make them. But I suppose with all of those, I think there's been a new paper. Was it this year, Benoit?
Yeah.
The single leg rise test was one that came out for FAI. That's
yes, definitely.
Think of it as a single leg sit to stand, guys and girls. So if you've got a bench that's about 60 centimeters ish in height, roughly, you want to see, can they do it, and how many can they do, one side versus the other. That's a good endurance test globally. There's the double leg or the single leg bridge. Have they got the capacity, the pelvic control to do that? I think a side plank is also another very good one as well. Obviously, it's the entire body that you're training, but I suppose in a hip context, you're looking more, have they got that lumbo-pelvic hip control stability to be able to do it? They're probably some top ones to see, have they got the capacity to do so? They can also be nice exercise initiators as well. I would say, Benoit, if someone can't do a single leg bridge, start them with 2. Short lever versus long lever. Do we do a short lever side plank? So it can also be ways for you to think about, how are you going to start prescribing exercises for this based on where you see these deficits.
Yeah. And there are a few things which you might not do on the initial assessment, which could be more relevant at a later stage. So a couple which comes to my mind would be, for example, in a runner, you might do a gait analysis if it's pain appropriate, if it's appropriate. In some people, high level sports, you might also, I refer to my colleagues for things like force play testing, counter movement jump. So there's a lot more add-ons which are not essential, but that sort of completes the picture. So as technology is getting more common now in most clinics, so we have a variety of sources where we can sort of add on. But again, I don't think it's necessary for that initial setting the scene, especially if they're irritable. But you might say to them that there are a few more things I'll need, but not a priority right now as well. But I think, before we move from here, one of the things I'll be interested in is, how do you sort of explain this sort of findings and all that sort of, because people want to know what you're trying to make sense of this to a patient. So how do you sort of sell this, or sort of put this package once you've done your objective to the patient? How do you sort of interrupt that to the patient?
Yeah, I'd probably say from my experience, it's quite eye-opening for the patient. If we take the runners, for example, it could be quite, because we know runners are notoriously bad for strength training. So when you highlight these deficits, it can be quite eye-opening to them on, I probably need to get stronger. But I think, as we've already alluded to, I do make sure I tell them, you're not weak. Because if you're an active person, which we know FAI affects the active population, if we compare to a non-active person, they're not weak. That's not what's happening. They temporarily become weaker for the task at hand, which might be running. And a lot of this has been driven by pain or fear avoidance, sensitization. So it's important that we explain that to them and say, you're not weak. This is the effect of pain, is what's happened here. So these are the strength deficits that are the result of pain, because you've naturally changed how you do things. You've stopped doing certain things because of X, Y, and Z. So we just need to start trying to find an entry point where we can challenge these muscles, where we do feel sore the next day, but it's not causing your familiar hip pain. And if we can tackle this for, let's say, a standard strength program, we're going to need to look at anywhere from 12 to 16 weeks to start building any physiological gain. That's what we need to look at. But today, with these strength tests, we're trying to find an entry point on where can we start you, where an exercise is challenging but not painful. And can we build on that over the weeks? And if we build up enough strength, power, stability, control, we can keep running till we're 100 and still have this CAM morphology. We just need to build that capacity to get there. That's probably how I would try and frame it.
And I find whenever you do a very thorough, because most of the time, like patient comes in, pretty much by the history and the profile, the imaging, I pretty much know the diagnosis because they fit in the pattern. But I feel having a thorough objective examination is so important to get compliance with the rehab. So sometimes I do that whole, schedule of testing where pretty much I knew the answer already, but I feel like it's more for the patient. I have to do it for the patient because they feel valued. They feel like you're really touching them. And sometimes there's a back paper which came like the assessment itself is a treatment. So because it sort of becomes like a part of thing. So sometimes the whole schedule and the whole, the sequence of testing is so important because then you can say, because I hear, you worked in FCP and in many places. So one of the common things I say, people tell me is the GP didn't even touch me, and how can I say I've got this problem? So the therapeutic touch, the validation, you can't expect people to follow your rehab if you're not really done a very good job on both listening and touching and also validating. Would you say that's important for the rehab journey?
Absolutely. I think you framed that very, very well, because even in FCP consultations, it's why we started off and I said, oh, can we modify the symptoms? Can we adjust how you're doing something? Because if they come into me with the belief on I can't squat anymore, well, let's find a position where you can squat, and automatically the belief's there. Also, I can do it. I just can't do it how I thought I was meant to do it. I just have to do it differently. With manual therapy, but Benoit, and I'm quite pro on the effect that manual therapy or symptom modification with your hands can be. And you can put someone's hip into passive flexion and it's painful, but can you do something with your hands to maybe desensitize those symptoms so that they have a bit more belief that they can do something? So I think that's very powerful. And all of the testing that we've mentioned here, it is for me to inform where is the baseline, where is the exercise intervention going to commence. It massively informs what we're going to do, and it helps them as well. And as you said, it makes them feel like that they've been given the time of day, I suppose, in the consultation.
Yeah. And I think there's no like perfect examination schedule or a routine because one, it's going to be based on the setting and it's going to be based on the time you have. And it's going to be based on, for example, are they seeing for the first time or a specialist review and the technology you have. But again, as any clinician, it's important to have a core set of testing, like your own little bit of package where you can build up and then you can build up. I'm sure when you do a 20-minute clinic, because most of the review I see is 1 hour. So because they have failed everything, I can't rush that. So how long do you get that in your work practice, Callum, in Australia? What's your
Yeah, so at the moment, the generally I would say it's about 45 minutes. You can get an hour. So again, if it's one of those chronic cases and it's failed, those hour appointments are available. But I would generally say it's 45 minutes, which is more than enough time. When we're thinking if we can pattern recognize from our subjective, you could probably confirm it quite quickly that it's FAI, probably within 20 minutes. But then if you've got another 15, 20 minutes to do everything else that we've just said there, it's very, very valuable for both of us. Yeah, for sure.
Yeah, definitely. Yeah. So I think we covered quite a bit today. And I think getting that solid subjective history and then you sort of confirming that with the objective is crucial. So I think for me, what stood out one was first thing is really be mindful of the irritability and the message you're saying to them and warning them before so that they feel like you're not really causing any potential irritation or damage. So that will set the scene. And then starting with, as Callum mentioned, their functional task like your squat, your single leg step down, your bridge sort of thing. So you really are testing how they move. We should be careful not to label them that it's sort of it's not there's no like perfect movement, but I'm really interested in the symptoms, how they move, and how is it modified by making small changes in those sort of testing. And with most special tests, we know they are not really special because they're more like pain provocation. So still useful and important to again check with them that it's their pain they're getting and it's not something which they're having a discomfort. So that's really important. And also looking at capacity, so looking at the functional movement patterns and how they really use the global muscles. So looking for example, loss of control, lateral trunk lean, compensatory movements. So those sort of things can be quite a normal thing for some people, they move, but again, it builds up your rehab checklist where we can really design your exercise based on that. And testing at strength, especially if you have access to handle dynamometer. So looking for as abductors, hip flexion, hip extension. So we expect them to have sort of the pain inhibition rather than genuine structural weakness. And that's something we want to give them a benchmark, and also reassuring them that we can really build up on that. And that's more because of their pain. And finally, looking back and looking at the whole system, don't examine the hip in isolation, test the entire kinetic chain, and also looking for how they, look at the person behind the pain. And many of the patterns comes from the training as well. And finally, sort of, feedback to the patient. What does it mean to the patient? You say that this is what I found, this is what I can improve, and this is what you need to do. So they come out feeling a bit more. What you don't want is to confuse them more with more and more information, because sometimes more information is not necessary. Is having a structure and clarity. So I think that's what we want at the end of your objective. So ideally, we've done both. And then when they leave us from today, they're pretty much, they feel they got a plan. So anything more you would add there, Callum?
No, but you're the master of summarization. Nothing more I can add there, mate. You're all good.
So that's good. So I think that's where we're going to leave it for today. And the next coming episode, we look into more like the imaging side. We look into things like the mimickers. We look at other pathologies we sort of mimic, because it's not going to be a straightforward case where people think. Many times I thought it was hip impingement, but sometimes with the imaging and the other things, they are not the same. So that's why we love this area, because it's never predictable all the time. But again, we can look into patterns. So hopefully that was useful. Please follow us and subscribe to us, and we're all over on social media. And also we can check out on our upcoming courses. We have a couple coming up in London, and we also plan to do one when Callum is back from Australia. We might do a joint event when he's back. He might choose not to come back. He's enjoying.
I'll be back. I will be back tonight. I will.
Yeah, I saw that. But thank you guys. Thanks for listening, and hope that helps in your clinical practice. Till the next episode from Straight from the Hip, honest conversation about hip and groin. Thank you.
Take care.